Okay, so it is 6:30. I'll go ahead and get started. Okay. You can start popping up in chat. People are still rolling in. We're going to give it a couple minutes. And I see somebody is also from Florida. I'm glad it's sunny where this person is because it's definitely raining today. Oh, I see somebody's from NOLA. I was just there with Marie for our West conference. This is actually Winston. Got Wisconsin. Yes, that was my first time in New Orleans. Yeah, I still love the culture, the music, and all the food. Anywhere with good food is good for me. Congratulations. Unfortunately, I didn't all food. I did not say no. And everybody was like, try this, try this. So yes, I did. I did, yes. We got somebody from Texas, Michigan. Yes, to the comment, tell people to be 10 pounds before going to Maryland. Yeah. That's related to our conversation. With eating, actually. Somebody joining in from the UK. Fun fact that is relevant. I want to learn. Thank you for joining us, especially with the time that we're going.
Ajua, you've gotten a little echoey again. And so I don't know what happened there. But you're good to go, ma'am. I'll let you once you can fix that. Yeah, you were a little echoey again, but
Okay.
and then I'm gonna
Still
get
or
the camera and
something
let
like,
you take over.
are we good with the no echo anymore?
What are you guys hearing? Is it an echo?
It's like a little almost muffled kind of
Yeah.
Okay.
sound.
Okay. I'm going to swap my devices real quick and then I'll jump right back in.
Okay. While she's doing that, I'll just welcome everyone. My name is Marie Boone Clark, and I'm founder and executive director of Birthing the Magic Collaborative. I am incredibly excited to have you all join us this afternoon for a topic that's near and dear to my heart. And I made that comment, and the person looked at me odd, and I'm like, well, don't you think something about weight and obesity and wellness would be important to a woman that looks like me? Um, so I was flattered that they looked at me odd, but then at the same time, it's like, But as someone who actually went through a fertility journey as a person who's fluffy, as my grandchildren say, I know it's a critical conversation and one in which is often not handled with the delicacy that I know these two women will give the topic. And it's also something that we often are a little embarrassed to talk about with our physicians, with our friends. And so I'm excited for this permission in a very safe space for us to have an unvarnished conversation. So at this point, I'm just babbling while we wait for Ajua to rejoin us. We're doing some tech testing. I am really excited for you all to meet. If you haven't met Dr. Shani Belgrave and Dr. Uchechi, who've done workshops for us before and are wonderful friends to BTM. I will do one quick announcement. If you missed it as we were doing our credits, Birthing the Magic has these beautiful, beautiful shirts that were created by Stoop and Stank, which is a cultural merch brand out of Philadelphia, Black woman owned. You too can own one. And so I'll drop the link in our chat. And Ajwa is back. So Ajwa, I will let you take over and I'm going to go off camera and take copious notes.
All right, thank you. Let me know if you hear my sound okay, if I'm good. awesome. I appreciate technology. Sometimes it works with you, sometimes it does what it wants to do. But here we are. Because of technology, we can all connect here in one space and get ready to start this conversation. So thank you very much, Marie. All right. Well, good evening, everyone. And thank you for taking time out of your day to hop into this conversation. I don't know about you, but I'm excited to talk about it. I love getting into topics that people tend to shy away from, but they're so necessary. They're absolutely necessary. So without further ado, I'm going to start by introducing our awesome speakers. Well, I'll tell you a little bit about myself first. My name is Adjua Ayesu Greenlee. I am a full spectrum doula located in Jacksonville, Florida. Somebody said that it was sunny where they are in Florida. It is definitely raining here. It is not my favorite time of year when the rain is kind of unpredictable at 4 o'clock, but here we are nonetheless. I'm waiting on my beach days. I am a postpartum advocate. I'm a birthing advocate. I'm a wellness advocate, all things baby, beyond, all that stuff. I'm a homeschool mom of 4, and I am excited to be here. So the first panelist I would like to introduce is Dr. Shani Belgrave. Dr. Shani Belgrave is a board-certified general and bariatric surgeon. She specializes in metabolic and weight loss surgery with a strong focus on helping women navigate their health journeys with dignity and evidence-based guidance. Dr. Belgrave is also the host of the Coalition Talk Show, which is dedicated to health, wellness, and inspiration. Welcome, Dr. Shani Belgrave. And I would just like to ask you to share with us, what's your why? I know we're going to get into some awesome topics and everything, but I would just like to know if you would like to share with everybody, what's your why and what is it about, what do you love about what it is that you do?
Well, first off, thank you so much. I'm so excited to be here with everyone, and I have such an appreciation for Birthing the Magic and all what is done with the collaborative. As you said, I am Dr. Shani Belgrave, Atlanta bariatric surgeon. My passion is weight loss surgery, and my why is getting to participate in someone's health journey in a way that's transformative. And I love the process of meeting a patient at the very beginning, understanding what their health challenges are, what difficulties they're having, and then the 6 month, and then even the 1 year, oftentimes we just embrace because it's like, I can walk the amusement park with my kids. I'm off insulin. I have a whole new lease on life, and just being able to participate in that kind of a journey is extremely rewarding.
Thank you for sharing that. Yes, and as a postpartum doula, we will definitely talk about the small milestones that are very big victories when it comes to making it through postpartum. Okay, and next we have Dr. Uchechi Emeruwa. Dr. Uchechi Emeruwa is a board certified maternal fetal medicine specialist. She provides high-risk pregnancy care with an emphasis on equity, science-based care, and a respectful engagement. Her work addresses how complex factors like body weight, underlying conditions, and system-level buy-ins influence pregnancy outcomes. Everybody, welcome Dr. Uchechi Emeruwa. So same question for you, what's your why?
Yeah, I feel like I've answered this to myself so many times, and then you ask, I'm sure I'm going to start listing off a host of things and come back to something later that I still feel like I forgot. There's so many things I love about what I do. But first of all, again, thank you guys for having me. As Marie mentioned, I've had the pleasure of doing some of these webinars and having some of these sessions with Birthing the Magic Collaborative, and I'm just always very thankful to be in a space of like-minded individuals and people who are just interested in kind of working together and collaborating to have a conversation to see how we can all work together to improve our health and our outcomes in this space and in this system. So thank you for having me. I would say my why, if I could kind of flash back to when I first started doing this, is, I remember kind of choosing my specialty and saying, wow, how beautiful to be able to care for people and participate in their healthcare in what's supposed to be a happy time in their life, not one that's supposed to be riddled with illness or complications. in the process of going through my training and seeing what I've seen, I said, you know what's even more powerful than being a part of this happy time is recognizing the extent to which people are willing to go to put themselves and their bodies on the line to bring new life into the world and expand their family. And so to be a part of this time in a life in their life in a time when there are a lot of things that could go wrong, and there are some very scary things that could go wrong, and just creating a space to help people navigate building their family in a way that keeps them safe as best as possible and brings life into this world was the icing on top. So I think being able to see the journey of expanding your family and keep people safe, even when they are willing to put themselves further out on the line than science might recommend, because it's very powerful to drive to kind of build a family, to grow your family, become a parent. So I think we'll sum that up for now as my why.
Thank you for that. And you are correct. It's a journey that has just so many layers, levels, twists, and turns. And to be in a position to walk alongside somebody for both of you, that's a beautiful, beautiful privilege to have. So let's get started. My first question is, what are some common myths about weight and fertility that you frequently encounter in your practice? And I'd also like to expand on that question and ask, where do you think this comes from? And I will let either one of you go ahead and answer that.
Yeah. And Dr. Belgrave, feel free if you have an answer primed and ready.
Yep.
Well, what I would say is that when I meet patients, because so many patients that I treat are women of reproductive age, a common question is, can I have a baby if I have weight loss surgery? And so my understanding of that question is that there's some concern over weight loss surgery impacting their body's ability to carry a child. And so I think a lot of people don't realize that obesity in and of itself affects fertility as well as having a healthy pregnancy. So that would be what I've experienced. Is I think sometimes people just may not be aware of that connection.
Yeah.
That is really interesting. It's helpful to hear, right? Because by the time I do preconception consultations, but by the time I see most people, they are either already pregnant or they've already decided or known that they're going to get pregnant. So I don't get that side of it where people are even wondering about the possibility of how, treatments or therapies for helping with weight loss might impact pregnancy. And I would say, I think we chatted a little bit about this. It's almost on the converse side for me, whereby I mentioned that a lot of times because weight gain and weight, especially in our culture, is so riddled with stigma and bias, I often find that we're less able to communicate in a very matter-of-fact way the flip side, the risks with weight and pregnancy outside of aesthetics, outside of, how it's romanticized or not, or stigmatized or visualized in our society. And so just being able to walk people through it not being a conversation shrouded in shame or guilt or blame, but rather like, how can we help reduce risks, medical risks, which is more of a conversation that I can sum up in one answer about a myth. But yeah, I see the flip side of it as, what are the medical concerns that are actually valid and not just about how we look and how we're being perceived, how we're being judged on our behavior, which is certainly an aspect of the country and this culture.
Thank you for that. And the thing about myths and misconceptions is that's what you know before you actually know. And so when you do know, when you have the knowledge, what does that look like? And that actually leads me to my next question is, both of you touched on a little bit about kind of dispelling some of these myths, but what does the science actually say about the relationship between weight and conception? Because just as Dr. Belgrave said, some people don't know. Some people don't actually are not aware that there is a correlation. And so again, what you know before you know, now that you're faced with everything, what does that look like once you provide them with the education?
Yeah, so it's interesting. There is a twofold increase with time to pregnancy in women that are obese compared to women that are not obese. And so that it does have a negative impact on fertility. That's been shown in the science.
Yeah, absolutely. And I think, again, recognizing that, you know, BMI in and of itself can't really characterize people's risk, but, you know, that relationship is pretty clear. You know, when you get to the overweight category, 25 to 29.9, obese, 30 and beyond. And of course, there are different classes of obese. You know, what is underlying this that I think we don't communicate as well is what's really happening is like the cells that hold the fat in our body, adipocytes, that is a metabolically active organ, right? And so that is releasing substances, helping regulate substances in your body in a way that is changing the baseline functioning of almost every system in your body. So, you know, it's not cut and dry that everybody with a BMI of 33 has the same metabolic function. Why? Because some people will store that fat cells more around hips and thighs, which is different function than the one that stores it in your belly and around your organs in your belly, which we can't see from the outside, right? But the fact of the matter is, like, there is some correlation. And so this increase in wherever we're holding the fat likely matters, not in a predictable degree from what we can tell from the outside, but it does matter. And because the reason I think it's important to share that this is an active organ is because that helps us start to understand why it's causing these effects, right? Like, why does it take longer to get pregnant? So many different ways it affects, but this metabolically active organ that's changing your hormone levels affects how your brain connects to hypothalamus, to the pituitary, to your ovaries. So it affects the quality of your egg cells. It affects how your body's able to release an egg cell, which is why some people don't have normal periods, you know? It affects the lining, they think, of the inside of the uterus where an embryo can implant to be able to hold the pregnancy. It impacts how the placenta develops and why we get gestational diabetes, preeclampsia. So it certainly, we think, because of one, how it affects your menstrual cycle and even being able to release an egg, to how healthy those eggs are, to how healthy the landscape to implant is. All of those things, I think, go into why and how increased weight does make it harder to get pregnant and to hold a pregnancy if you do conceive.
I really wanted to echo what you said, Dr. Emeruwa, because that's something I'm telling people every single day. Again, speaking to your point that this isn't a judgment thing, this isn't an aesthetic thing. This is that when we talk about excess fat, it is actually producing cytokines. It's not just something that's just there. It is playing an active role in your health. And so I just wanted to echo that because I think it makes it easier to have a open judgment-free conversation where you're not saying, oh, it's because you look a certain way or this or that, but hey, there's a correlation when we tend to see these BMIs. We see a correlation with these other health issues because of the biology of the whole situation.
If it
Thank
were
you.
just about giving me my curves, I would sign me up every day. I could use a little extra in certain places, but I can't control where mine goes. So I'm just gonna have to take it the way my body comes.
Yes, we cannot control where it goes. And thank you for following up with that, Dr. Belgrave. Now, both of you have used the term BMI, and if you could just quickly educate, because some people hear the term thrown around, but they don't actually know what the acronym is for. If you could kind of explain what the BMI is and why people usually argue that it's not the best way to measure health for Black women in particular, and kind of put in a little bit of context for our participants, please.
I would love to. So BMI stands for body mass index, and it's a number that is derived from a person's height and weight. And so as we were kind of alluding to, if you look at the textbook, it'll tell you, okay, 18.5 to about 24.9 is ideal. And then there's like an overweight category. Then you have the different categories of obesity, with obesity starting at a body mass index of 30 or greater. And so when I have the conversation with patients, I acknowledge that it is not a perfect tool. However, it is very useful and helpful because for a lot of conditions, the data is there that over these BMIs, you start to see increasing risk of high blood pressure, diabetes, certain cancers. So we know that there's some value. Some of the reasons why it's not a perfect tool is because it doesn't account for certain things, like we kind of alluded to earlier, how your weight is distributed, because we know that central obesity or weight that's carried in the abdomen is more problematic than weight that's carried in the buttocks and in the thighs. And so culturally, depending on just how women are shaped and how they're built, there may be some variation, but also it doesn't account for muscle. So certain people that are very muscular, like if you look at certain athletes, people who are extremely tall and extremely muscular, some of those people, just based on that alone, may fall into a particular category that medically isn't really consistent. But overall, I think it's a useful tool. Some of the other things that have been talked about are like the waist to hip ratio, again, kind of getting at measuring central obesity.
Thank you. Thank you for that. Dr. Emeruwa, would you like to add anything to that as well, as far as where BMI falls in relation to fertility and conception?
Sure, yeah. I think I guess the only thing I'd really add, I mean, that was like an excellent summary. I almost have nothing to add, so maybe I'll kind of expound upon like what we start to see in pregnancy and how this ties into things like the weight gain recommendations, right? Because for example, our weight gain recommendations in pregnancy are dependent on your BMI category. If you're starting with a normal pre-pregnancy BMI, there's a greater weight gain allowance than if you're starting in the obese category. And again, like so many of these things are so like multi-layered and multifaceted. So I'm trying to kind of keep it succinct as I talk about some of these risks. But pregnancy, you're gonna gain weight in pregnancy, right? That is a time in life when you are growing a whole being, you're supplying a whole organ. The level of nutrients that you're transferring through your body is increasing, right? So we know you're going to put on at least enough weight that will weigh a baby. You're going to put on at least enough weight that will weigh the amniotic fluid, the placenta, and then that's not accounting for the growing amount of or expanding amount of blood volume. When you get pregnant, you add on a lot of water weight, so to say. You expand the number of red blood cells, like everything just increases, right? So we know like if you are a normal weight or underweight person and you gain no weight in pregnancy, it's problematic, right? Because something is adding on. It means it's just depleting from your stores. Now, when you start at a higher weight, the reason we try to regulate, or it's recommended to regulate how much gain, is a couple things, right? Because okay, we know there's a baby and all these things that are adding in that weren't there before, but there's some data to show that, for example, if you are starting at a BMI, let's say 35, and you are putting weight on in pregnancy, where it distributes is going to be more likely to distribute in that central or abdominal region compared to distributing in the peripheral region, the buttocks and the thighs. And we know that that central fat distribution is going to be more lead to more complications for your health, and actually even for the baby's health that you're growing, right? So it's okay to not gain as much because we have our own stores of the fat cells that we already had in our body that the body can use to produce that energy, and we don't want to risk depositing more of the excess weight in the fat that's going to be around your abdomen and your organs. On top of that, we all know that it is very difficult after delivering to get back to your pre-pregnancy weight, right? So if you go into pregnancy, let's say you can start at a normal weight, you gain more than the recommended. So more than we think the energy is going to be necessary to grow a baby and to feed that baby postpartum. Then it's going to be hard to lose it, right? After delivery. But most people don't want to wait 5-10 years before having another baby, right? We want to make good use of our reproductive years. We want our kids to have siblings that they can play with, right? So you're pretty soon gonna jump into having the next kid. And if you didn't come back to your pre-pregnancy weight because you gained excess weight, now you're starting at a higher weight and potentially going from starting normal weight to an overweight or obese category. Then that weight adds on, and instead of adding on in the less problematic places, it's more likely to add on into the problematic places. And the cycle just compounds itself and compounds itself over and over again. So I think knowing that, you know, we're trying to both mitigate or help not compound the problem for later down in life when we're out of our reproductive years, when it's going to be even harder to lose that weight, and how that weight distributes depending on what your starting weight is, all helps us guide how can we get you through this in a healthy way without adding on to chronic problems later in life for the sake of you growing your family.
Thank you for that. That was really good. That was really good. And I like the way you explained, you within a short period of time, you think about having more kids, and then it's kind of like you don't quite go back. It's like a rubber band stretching. You don't go back to the original the shape of the rubber band. It has a little bit of a stretch to it, has a little bit of extra, you know, pull to it. Then you kind of go a little more, have more kids. And so it does become a cycle. And I like that you added looking at kind of how you're going to manage through that time period. And so that kind of leads me to my next question. These are difficult but necessary conversations. And it's difficult because of the stigma surrounding weight and women and our emotions and our appearance. And you have things in society and media, all kinds of things that are playing into the conversation around weight. And so, Dr. Belgrave, for you as well, are there any specific lifestyle changes or recommendations that you would encourage or suggest to a patient who is trying to conceive but might have a higher BMI?
Yes. So things that I say we all should be doing to be as healthy as possible is exercise. Ideally, daily exercise if we can, but if not, a minimum of 3 times a week, as well as being very mindful with what we're eating, because a lot of obesity, while obesity is a chronic condition, it's multifactorial. It can be environmental, part of it can be genetic. There's lots of different things. Part of it is also behavioral. And so I kind of counsel people to really do a lot of plant-based. We know that produce, lots of vegetables, lots of greens. Fruit has some nutrients in it as well, but just to be a little cautious with how much, because fruit can also have a lot of sugar. And then I always counsel everyone to really stay away from fried foods and ultra processed foods, because we know that ultra processed foods not only are associated with weight gain, but they tend to cause a lot of problems in the body. So those are the things that I always say everybody should be doing for weight management and health, but particularly for people that are morbidly obese, depending on the degree of obesity, I do recommend bariatric surgery. That is the most durable and effective treatment for obesity that we have. And so for people that have a body mass index of 35 or greater with a weight-related condition, high blood pressure, diabetes, sleep apnea, I think those people should all at least have a consultation to have the discussion about weight loss surgery. And certainly anybody that has a body mass index of 40 or greater, even in the absence of a weight-related health condition.
And if I
Thank you.
could just tack onto that really quickly, you know, I think I remember you mentioning, Dr. Belgrave, earlier how a lot of people come to you and be like, well, I'd be able to get pregnant or have a pregnancy after I have surgery. And I think what's really important for us to share is that if you're starting at a weight in which you're more likely to experience chronic medical conditions, an unhealthy weight, so to say, if anything, not only did we already talk about how it can make you more likely to spontaneously get pregnant or get pregnant on your own, you know, you kick your body back into normal cycles, but it actually also reduces your risks. I mean, provided you wait the recommended time, et cetera. There's so many recommendations, things to follow, but when your body weight comes down, again, those adipose cells are decreasing in number or in activity, it's going to also save those pregnancy-related complications, or at least reduce those risks. So like gestational diabetes, preeclampsia, risk of C-section, risk of early delivery. So again, any condition that we're helping treat in ourselves, I always tell people come into your pregnancy the healthiest you can. They always ask me like, how can I make sure I get through pregnancy, not be high risk, be good, my baby be good. Whatever version of ourselves we're coming with, whatever conditions we've been dealt in life, when you make sure you're at your healthiest that you can be, that's step number one. So, not saying everybody needs surgery, but certainly like if you meet any of the criteria that Dr. Belgrave was discussing, or you're concerned about your weight, a consultation is a great start just to understand like what are the targeted strategies that make sense for me to help me get to this healthiest version of myself.
Thank you for that. I have another question for both of you. Given the topic that we are discussing as it relates to womb wellness, how challenging do you find it navigating this conversation to women specifically in addressing weight? And it's a very sensitive subject. It can be, again, kind of like Dr. Emeruwa was saying, it has so many layers to it. It can be traced back to traumas, any type of triggers or anything. How difficult do you find it to navigate these conversations in finding a balance between educating and providing science and also having compassion?
I feel like Dr. Belgrave may have even more insight to add on, so I'll start first so she can finish off with the banger. But I will say, I think like as much as I'm freely talking about it here, I will admit myself, like it is a hard subject to broach, right? And especially because a lot of time when I'm seeing birthing people and reproductive age people, they're already pregnant, right? They're already at a very vulnerable moment, and pregnancy is not going to be the time I ask you to lose weight. We may talk about regulating how much you gain, but like I'm not going to say this is the time to like get on your P's and Q's and do everything we can to help. That's not the goal here, right? That's not healthy. So it's tough to address, I think, for that reason. Even though there are things, and what I think is challenging is you still have to talk about the risks, right? I still have to talk about, it may be harder to detect certain abnormalities that could be developing in the baby because it's hard for the ultrasound technology to see through to the baby if you have additional layers, right? There are things that are kind of unspoken or subtext, and I know patients feel too, like people we're caring for feel these things and they kind of know. So having it being the big elephant in the room is tough. I think I always, there are certain words that I think are riddled with, again, more stigma than others that it's tough. We try to stay away from, right? Obese, I will admit, like I have to write it in, not I have to, but like I write it in my notes because that is a medical term. It's a medical term. It means something very specific. It has zero to do with how I feel about anything about the aesthetics. But, to patients, I don't typically use the word when you are obese, right? Because I know that's riddled with way too much. This is not a time to increase anybody's vulnerability. I might say whenever you have excess, whenever we have excess fat cells, I'm making an inclusive thing because it's something we all struggle with. And I try to use language that is appropriately still clinical and matter of fact so that it's clear that this is a medical thing, but isn't placing judgment. The other thing I'll try to do, I say is, I try to, especially as we get towards the postpartum time, and we're working towards that time, acknowledge the challenges of what it's going to be like to get down to the weight we want or improve our health, and making it understood that this is a collaborative effort to see how can our healthcare system support us being our healthiest. And weight is not the only thing. Mental health conditions fall along those same lines. And we live in a society that doesn't make it easy for us to be healthy or healthy weight. Talk about processed foods. You know how hard it is to find things that aren't processed if you have to buy something quick and not make it yourself or go to the farmer's market. Like just making it understood for patients. I try to come from a perspective of understanding like this is a systems thing, it's a cultural thing, it's a community thing, it's a modernization thing, and we are all working together with the same struggle to help support what is going to be targeted and right for you. So I don't know if that really answered the question. So I'll let Dr. Belgrave maybe get into some more.
It did. And I just love that because I think you hit two key things on the head. Number one is collaboration. Let's work together to kind of get you to your health goals. Because I think when you come at it from that standpoint, no one's feeling judged, no one's feeling attacked. I think people are relieved. I have an ally, somebody that's trying to work with me to make sure I'm living my best possible life. So I love that. I do think that it's absolutely collaborative. The other thing that I really appreciated about what you said as well is the bringing up the medical term obesity, because you're absolutely right. That's a medical term. And I think sometimes when people hear it, they may just feel away. So I always, early on in my consultation, I just use it as a definition. Oh, this, when you have excess body fat, that's the medical term for obesity. And this is how it's categorized based on these numbers so that we all understand it's just a definition, like a literal textbook definition. We're not assigning blame, judgment, ridicule, nothing like that. And so I think trying to make certain things objective can kind of, make everybody in the room, you as the clinician, the patient, that we're looking at all of this from the lens of health and how can we win? How can we get healthy? So I'm glad that you had the same idea in terms of the approach, because I do agree it can be tricky because you're trying to help, but sometimes if things are discussed in a way where a wall goes up or a barrier goes up, then you may not be able to give the help that you're trying to give.
And I
Awesome.
really love the idea of collaborative, because I think it's as with any medical condition, when we're overly prescriptive or just try to give a one size fit all blanket, you need to eat less, you need to work out more. That's clearly not the summary. To boil it down to that for any and every one of us makes zero sense. And then if it's clear to the person on the other side, you're not really invested, you don't care, you don't understand the restrictions and the constraints of my life. It is a multifaceted approach until we really feel like we're building a relationship and understanding each other from the medical side, from the personal side, and then merging them to work together with a team. That's, I think, honestly, what ends up helping people further their goals.
Yes. Thank you, ladies. I agree. And that word collaborative, community, together, the acronym team, together, everyone achieves more, that completely fits here because you can't put the burden on the patient like that. It's what can we do? How can we support you? You see better outcomes when patients, clients, they feel like they're supported. Otherwise, this is exactly the type of thing that keeps our community from going to seek medical help. And so if you feel like you're being supported and encouraged and informed, you're more likely to kind of get on board and be an active participant in your health and wellness. So thank you for that response, ladies. My next question is for Dr. Belgrave. And Dr. Emeruwa, of course, please, I would love to hear your input as well. How can someone considering weight loss surgery think about future pregnancies? What is the ideal timing?
Yes. So I think it's so important to counsel patients that after weight loss surgery, they need to prevent pregnancy for at least 1 year. Some articles will say 18 months, some will say 2 years, but at least 1 year. And the reason is that it has to do with the stage of rapid weight loss, because as a patient is rapidly losing weight, we don't want them to become pregnant due to certain concerns of nutritional impact and things that could affect the infant. In terms of growth restriction, prematurity, and certain birth defects and things like that, depending on what's going on with their vitamin levels and their nutrition. So at the very beginning of the process, I always like to start there just so everybody can be planning, like, okay, if I'm going to have this surgery, what's going to be my contraception? What's going to be my method of pregnancy prevention to make sure that I can do all that I can to have a healthy pregnancy when the time is right.
Thank you. Thank you for
I echo that. I think, as you alluded to, a lot of people who may not have been having regular periods or may not have been able to get pregnant, who have an increased BMI, may not realize that you don't know how quickly your system could kick back into gear and start ovulating and releasing eggs and get pregnant. And it may not be at the time of regular periods. Maybe you have a little spotting, maybe you have no change that you recognize, and your body has silently kicked in. So, it's with any patient I say who's not, unless you're actively planning pregnant or you're okay with the pregnancy and know it's safe, we should be actively deciding the best way that we're going to hold off on it. So you don't get caught with any surprises that might endanger you and or your baby.
Yes, thank you. And that is very important. I think what you both also touched on was what's happening to your body, the biological changes that happen after having surgery. And going back to what you had said earlier is in our bodies, in the way we work, is kind of like everything is an organ. And I think what's missing a lot of times is the lack of the education behind what's happening. Sometimes you go to the doctor and they just tell you this is what we're going to do and this is what's happening. And there's no room to ask questions or to feel like you're being educated. And so in something like having weight loss surgery with that type of circumstance, with the risk, you want to know exactly what's happening in your body because it can affect your baby, right? And so Dr. Belgrave, you mentioned birth control. What are some of the options that you provide to your patients in explaining to them about avoiding pregnancy too soon after surgery? Are there any ones that you recommend more so than others? If you're able to share that with everybody, please.
Absolutely. So I always encourage patients to also get weigh-in from their gynecologist, but and many of the gynecologists that I've kind of discussed this with tend to recommend either an IUD or an implant. And part of the reason is because the oral contraception, there is some concern with how well that's going to be absorbed after weight loss surgery. And so, especially for that first year, I think probably something that you don't have to factor that in, kind of just to be extra, sure that that pregnancy is going to be prevented. So I tend to counsel patients to think about IUD or an implant.
Okay.
Yeah, by and large, regardless of the condition or what we're trying to prevent pregnancy for, the most effective ones are going to be the ones that don't rely on our own behavior. On top of, like Dr. Belgrave said, ingesting and relying on the GI tract absorption has separate considerations here, but implant, IUD, things that we're not having to think about on our own, human behavior is imperfect for any of us. So that's, I think,
Yes.
typically why we tend to go towards longer acting ones, working, of course, with people and what their concerns are about them.
Yes, and I agree. Our tendency is routine. We have routines, but of course, with oral pills, it's exactly the same time every single day, and life gets busy. Things happen. Again, we just, as everybody uses the term, life is lifing. Life is lifing. And I take those risks after weight loss surgery because life will really be lifing after that. So thank you for those suggestions.
Well, I was just going to interject a joke because after my first baby, I told my GYN, oh, I'm going to breastfeed for pregnancy prevention. And she was like, you be doing that at your own risk.
Right. I tell people that is fine, but I've
Yeah.
told you the risks and I've told you it's not 100%. So as long as we're all on the same page, that's what I can tell you.
That is certainly one of those myths. What you know before you know. Thank you for that. And so I want to kind of transition into care for your patients. How can patients advocate for themselves if they feel their weight is overshadowing their concerns?
Oh, wow.
Yes. In Black maternal health, we, advocating for yourself when it comes to your health is a very, very big thing, as you ladies know, and as you kind of have echoed throughout our conversation. So how would you advise a patient to advocate for themselves if they feel like their weight is overshadowing their concerns?
As in the dynamics between themselves and the provider and the care they're receiving and all of that?
It could be both. It could be both. If that's kind of taking over their concerns. I'll share too, as a doula, some of my birthing clients have kind of stated that they don't feel like they're being heard mainly or being dismissed mainly because of their weight. And so they become very vocal and say, is my weight going to be a problem when it comes to the care of myself and my baby? Because at that point they feel like they're not being seen and not being taken seriously as patients, unfortunately. And so how do they advocate for themselves when weight becomes a big part of the conversation.
I'm speechless, and I shouldn't be, right? Because,
Yes.
I think it's almost like, when people say, I went to the doctor and I could tell they were dismissing me because, I'm Black. Like, that's very real. So I almost am embarrassed that I'm acting shocked about this, because fat phobia is also real. Like, I'm gonna call it what it is.
Yes.
Like, that term is out there, right? Because it's a true thing, in the sense that, like, as my sister put it, she's like, I think what's challenging is people see excess weight and they know there's health consequences associated with it. But you can be thin and also be very unhealthy, but people don't see it from the outside, so they don't
Yes.
same behavior, right? So I know for a fact it's a real thing. I'm just trying to imagine or put myself in a situation in which, I may encounter that, or a patient may encounter that, and think about what I would advise them. I mean, I think being very blunt about it, if you feel it and calling it out, that's usually my approach, but I'm a very outspoken person.
Yeah.
And, you don't want, nobody wants it to be a contentious relationship. So I think one obvious and easy solution that people will suggest is, oh, if you need to switch providers, switch providers. And I do resonate with that, and I echo that, but sometimes it's not as easy as it sounds, right? Like, it's not as easy to just jump to a new provider in this healthcare system with these insurance constraints, et cetera. But if that is a possibility and a certain personality doesn't work for you, then, and you notice there's some bias, because we all have our own biases, that's one option. I think the other thing is what we were talking about before is to, you mentioned this, Audra, like, sometimes it actually is one of my pet peeves when we go into an interaction with a patient and it's just, okay, this is happening, this is happening, this is happening, done. How can we expect people to follow what we're recommending is a healthy thing if we're not communicating what is the reason, what we're worried about, what the risks are? As you can see, I'm a talker, so I tend to do that at baseline, but not everyone does. So one thing I tell patients is to advocate with realistic questions, and sometimes it helps to make it very medical. Like, okay, what are the things we're worried about? Can you walk me through, with this symptom, what we're worried about, what we considered, how we know it's not something significant, right? Because those are the main things we need to know, right? Like, because some symptoms really just are, this is normal or physiologic or not dangerous. And maybe somebody's thinking that and they just haven't articulated it because they're moving in and moving out. Or maybe it is being ignored because certain things aren't being considered. But so when you're able to have that very objective conversation, like, what's the checklist we've gone through? What have we been worried about that we've ruled out? And when do I need to be worried? Like, what will change about my symptoms that you would be worried about, so that we can feel like it's actually been evaluated? I think those are some of the things I might be able to recommend or discuss.
Yes. And those are excellent suggestions. That's a big one. Switch providers if you feel like you're not in the best hands when it comes to your care. Absolutely. Thank you, Dr.
I was gonna echo that, but then the other thing I just thought of that might be helpful is if someone wants to stick with their provider and they just feel like there's certain things that are being lost in translation or they're not being heard, might be early on in the visit to kind of set the stage for the agenda. Like, these are 3 things that I would like to talk about. Because I think sometimes what can happen too is if it's just a visit where you just kind of go with the flow, and then maybe the provider is starting to run out of time. And then it's like, okay, we're at the end of it's a 15-minute or a 20-minute, and then the person leaves feeling like, well, I didn't get to everything. So I think if there's certain key concerns, maybe to kind of set the stage early on, like, oh, good to see you. There are 3 things I kind of really wanted to make sure we talked about and touched on. Might be a way to kind of make sure that they're getting all their concerns addressed.
And I like that. Set the tone from the beginning so you know what you're walking into. Um, show up with your voice from the very beginning. And then this is where, again, when you are educated and informed as much as you can be before the encounter, that makes for better outcomes and a better dynamic in the relationship, as it needs to be when it comes to your health. So thank you for those responses. This has been a wonderful, wonderful conversation. And so now I would like to open it up to our chat. We have time for a few questions, if you ladies don't mind. Well, let's see. I will let you pick one. I guess if you guys want to pick one each, which one you would like to answer. Let's see. I had a couple of them that popped up. And please, guys, please feel free to add a few in between.
There were a couple of questions in the Q&A, Ajwa. And I'm sorry, I was sending those to you and I was so busy writing notes.
It's okay. It was good information.
You answered one of them you guys answered one of them very thoroughly, which was how long after weight loss surgery should the individual wait to attempt to conceive? And thank you for that conversation. And then the next question, I didn't catch it, and was how do you balance the essential nutrients and minerals to ensure that mom doesn't become more depleted and that the fetus receives qualitative nutrients? I know Dr. Uchechi touched on it, but maybe we could highlight it for the audience.
Yeah, no, absolutely. I think, you know, this is part of why, especially as somebody who's a maternal fetal medicine provider, a lot of my patients I see in collaboration with their provider for whatever condition they were undergoing treatment for before they got pregnant. So whether it's your bariatric surgeon, if you're still somewhat close to your surgery, your weight loss, or your GI surgeon, or whoever's helping manage making sure your nutrition is optimized. There's a couple, right? It depends because it depends on the weight loss surgery you've had. Gastric sleeve, Roux-en-Y, gastric band, as to what the risks are and what nutrition you need. And we work together to understand, right? Because Dr. Belgrave is going to have a much better idea of, how much of these vitamins do I expect to be lost, or what levels do we normally monitor and try to keep it at? If we're keeping it at a level that's normal and healthy in a non-pregnant setting, that's why we work together to say, okay, how often am I going to check these labs? How much are we going to increase or change the supplementation? And to me, it's usually an ongoing relationship and co-management through pregnancy to make sure we're keeping those levels optimized. And the fact of the matter is, unless you're significantly deficient in these vitamins and nutrients, the baby will take what it needs from you, honestly, for the most part. So yes, we're balancing keeping the baby growing and nourished by checking those levels, growth scans to make sure the baby's growing, developing fine, but we're also making sure that you have leftover after what the baby is taking, is draining what you're already being supplemented with.
Thank you. And that's a perfect segue to the other question, which was around supplements. First part of the question is how essential are taking supplements post weight loss surgery? And then the second part is how long are they needed? And then particularly with reference to breast chest feeding.
Well, I just wanted to jump on that and say lifelong, because vitamin deficiencies can occur at any point. And so I just don't want anyone to think that, oh, my levels had been fine, everything was fine. And so I kind of just stopped taking my vitamins, because eventually certain stores can get depleted. Yeah, so lifelong.
Which tackles the question of the chest feeding, breastfeeding period as well. Yeah. I mean, I think, it's interesting because in our society currently, there's a lot of people who take a lot of supplements that don't need them, likely, right? If you are a normal healthy person with a normal healthy diet, save for a few things, most things you have adequate storage of. But this is one of those situations in which you may need to help your body because the absorption changes depending on what surgery you've had, et cetera, et cetera. I won't go down that long physiologic pathway, but yeah, you will need to help your body for life.
Thank you. I actually had a question. Is there a type of surgery that is recommended depending on the BMI? Like, or is it what the patient is preferring? How does that work? I literally just thought about this question.
That is a great question. And because these are kind of conversations I have with patients every single day. Well, what's the best surgery? But what's the best surgery for me, like me specifically? And so what I would say is that the sleeve and the bypass are the most commonly performed weight loss operations. There are a few considerations depending, not just on the weight, but depending upon some other things. Like, for example, bypass patients really should not take non-steroidal anti-inflammatory drugs because of the risk of ulcers. So if somebody wants a gastric bypass, but they have terrible joint pain and they're really dependent upon those medications, it's like, well, that may not be the ideal operation for you because we're taking that treatment off the table. So in that instance, maybe the sleeve, because you don't really have that ulcer risk with sleeve. The other thing is that both sleeve and bypass are great surgeries, but the sleeve does come with the risk of reflux. So some people may come in and they're like, I want a sleeve. And then it's like, oh, I have to take Tums every day. I can't sleep at night. I have terrible heartburn. I'm like, well, for you, the sleeve is not going to be the ideal because we're already dealing with bad reflux that there's a likelihood it could get worse. So as it relates to body mass index, there is more weight loss with the bypass than with the sleeve. So above certain BMIs, if, depending, then I would say probably the bypass is going to give the patient more bang for their buck. But that being said, there is, like you mentioned, I do have conversations with patients where maybe depending on their overall health, they could easily have a good outcome with either. And then oftentimes it's patient preference. And it's interesting because people fall on different, ends of the spectrum. Some patients will say, I don't like the idea of 80% of my stomach being taken out. I don't like that. Other people like, throw it in a bucket. I don't care. So a lot of it kind of has to do with patient preference as well.
Gotcha.
Can I
Thank
throw something in the ring about shall we touch upon or tackle the new sheriff in town, all the medications, injections, GLP-1s,
Mm,
tackling your experience with that, Dr. Belgrave, and weight loss assistance, and then I can jump in with the little, which is not much, but what we do know about it and pregnancy.
Absolutely. So, we have been also, as we mentioned, obesity is a chronic condition. And so many times, even with surgery, there'll be issues at some point in time where people are dealing with cravings or weight regain. And so I think that the GLP-1 agonists are beneficial and play a role. The thing that I always tell patients about that I think isn't really spoken of enough is that there's weight regain upon cessation of the medication. So that's been one thing to just I want them to keep in mind. I sometimes use them before surgery to try to get weight down depending on how obese the patient is, because we know over certain BMIs, the risk is higher. So sometimes I'll use those medications before surgery to get weight down, or in patients that have had a particular operation and need some additional help. And I also would love, thank you so much for this opportunity to say that even with the weight loss medications, it's so important to also do the lifestyle things, because with the surgery and with the medication, in order to have good results, you really do have to be doing the healthy eating, staying away from processed foods, and there is a role for exercise that does help as well.
That makes a lot of sense. And I have seen patients who were started on a medication, GLP-1 agonist, and then got pregnant before their weight loss surgery, because similarly, if you start to drop weight, what happens and your body starts ovulating, you didn't realize if, the provider you're working with and you didn't realize that you also needed a solid plan then, sometimes you can get pregnant even with that degree of weight loss before you complete your weight loss goals. So again, just a reminder to remember, if you're not trying and it's not the right time to try, that it's helpful to have a solid plan.
Absolutely.
Absolutely. Well, ladies, thank you so much for a very informative conversation about womb wellness and weight. I know I have learned a lot. I hope you guys have enjoyed sharing your knowledge, your information, and your why. I can definitely see that you guys are passionate about what you do, and we need more of these conversations for sure. We need positive conversations about weight and body health, all of it. Biology, there's a little bit of, I'm a sciencey person, so throw a little bit of science in there and I'm all in. So thank you very, very much for that. Please, let's have this conversation again. I know Marie is quick to set things up like this, so you'll probably see me back again. I will get your contact information. It's been shared in the chat. I hope all of our participants have enjoyed listening to these two experts in their field, and I appreciate you guys taking time out of your evening, because evening meetings are not easy, but when it's information like this, you can't go wrong. So thank you guys for joining.
And if
And
I could just, sorry, and on one note, just to circle
Yes.
back to what you said in the beginning and how we started this conversation, I think it is important for people to hear, like, there's rarely, there are sometimes, but there's rarely ever a situation when I tell someone you shouldn't get pregnant, can't get pregnant, it's too dangerous for you to get pregnant. You know, even with these conversations about obesity and increased weight, there's many complex things we manage through a pregnancy and able to get people through safely, but we know everybody, when they go through pregnancy, they want to come out healthy. They want their baby to come out healthy. So none of this is to say you can't or shouldn't, but it's like, you know what, how can we work to optimize your health and your baby's health to get you to a healthy end, so we don't end up with a preterm delivery or severe preeclampsia or something that, you know, could change your life trajectory. And so really that's all it's about. But by all means, I know we all want to expand families, not all of us, but a lot of us want to expand families. So we're just here to support that goal, right? And get there in a healthy way.
Yes, thank you for adding that too, because honestly, I tell people you just never know. Birth and life and the body, it does what it wants to do. Same thing I tell my kids, leave nature alone. Nature's gonna do what it's gonna do regardless. Okay. It's gonna happen. And so we have conversations like this. It's a collaborative community effort. And so at any point in your perinatal journey, postpartum, any of those things, there are resources out there. There are individuals like all of us on this call who are here to support you and guide you to the right place. So thank you for adding that, Dr. Emeruwa. Yes.
Thank you all. Thank you. The recording will be available later today, if not first thing tomorrow. Thank you, Dr. Belgrave, Dr. Uchechi, Ajua, which such a rich conversation. And we look forward to seeing you guys in June. We've got a teeny tiny surprise for what our workshop will be, but we'll talk to you then.
All right, I'll be back.
Thank you. Good evening.
Fine.